to begin this week?
I've got a couple.
Okay, we'll let David go first.
So this fellow had some oncologic history, which I will refresh. So he has a catheter in place for that. And he has just a little bit of stuff in this left base. This chest radiograph, is representative of his recent radiographs. And, maybe something down here, it's pretty vague, not for sure. Let's check it out on CT. And we'll see that there is indeed an interesting kind of abnormality in that left base. So at this point, we have this preternatural lucency. And then we have a very nice vessel coming off the descending aorta and feeding this. So this is a sequestration. And the question is what to call this lucency. Would you call that a CPAM or lobar emphysema or something like that, or overinflation, or call this a hybrid lesion, or just consider that sequestration can have hyperlucency as part of it. I've often seen a cystic abnormality in the center and then the lucency around it. So it seems that you can have almost all tissue densities involved in sequestration, from hyperlucency like this to soft tissue to cysts containing fluid and lowish attenuation. And then you can even see calcification. You can see calcification in the artery, which tends to have premature atherosclerosis. I don't think I've seen calcification in the retained mucus in these lesions. So an incidental finding of sequestration here, and on coronal, you can nicely see the vessel going into this big lucent region in that lung base.
So, David, I would call this a hybrid lesion because I think you have a convincing bronchial atresia in it, which makes sense with a sequestration. And I suspect there's probably CPAM elements. And there were some papers that in the literature that describe these. And if I don't remember the exact numbers, but bronchial atresia was very commonly associated with these sequestrations.
Right.
And it makes sense because it's sequestered lung, so it doesn't communicate really with the airways in most cases. So I call them hybrid lesions.
Okay, that's fine. There are all these different elements that you can mix together. So it's really a question of terminology. It's definitely messed up lung. And what people need, what I emphasize in teaching residents about this condition is that the term sequestration means something is isolated. And what is isolated is a normal airway communication. So these lesions don't have a normal connection to a bronchus. Therefore, the inflation of this lesion really depends on collateral drift from adjacent lung that is being aerated. So the air is getting in there from the lung parenchyma around it. It's not getting in there from a normal bronchus. So if there's a bronchial atresia component, or maybe this is really just a cystic component, it doesn't connect with a normal airway because it is sequestered. So maybe this is really just cystic stuff that we're seeing in here rather than bronchial atresia. So if the cysts develop a fluid level, let's say you don't have the surrounding hyperlucency, but you do have cystic stuff and you get fluid levels in it, that reflects fistulization and air getting in again from adjacent lung through a fistula. So, I'm not sure this really qualifies as bronchial atresia rather than maybe an isolated set of bronchial attempts down here that have some liquid in them and have some gas as well. But hybrid lesion is fine. Okay. And then this person has a very cruddy looking right lung base here, and I'll show you a lateral big blob back here posteriorly on lateral view in that right lung base, and then had CT scan that shows a big central mass here. Let's look at it with a soft tissue window, and you can see that it's got some low attenuated components to it. This was biopsied and it was a squamous cancer. This is a young person, I think. I'll check the age, but I think this person is only 29. So kind of young age for regular cancer. There's some other nodules here too. Here's one along fissure, And then we'll see there are some other lower lobe nodules here, and I think there's some others, and there's even something on the other side, a few little blobs. Here are some other lung nodules here in the right base, and then we've got this stuff over here. So this is all this is in the setting of respiratory papillomatosis. Now his central airways look pretty good. He doesn't have that usual rough internal surface or polypoid stuff in the chest CT parts of the trachea, but higher up near his larynx, he does have lesions that have been treated many times in the past. So this squamous cancer here is probably degeneration of one of these wart virus tumors into a more malignant form. And squamous dedifferentiation is one of the things you worry about in respiratory papillomatosis. Okay, so the respiratory papillomatosis with a big squamous cancer. So this was treated with bilobectomy and resection of middle and lower lobes. You can see the involvement crossing the fissure here into middle lobe. Okay, and then this person also has a convexity here that does not belong. That is, I think this exam is from 2017, and I will show you a later exam that shows that things did not go well for this person, and this thing got bigger and it developed a pleural effusion. So if we go back to this 2018 CT, this is a year after that first chest radiograph, you can see that there's a big anterior mediastinal mass with some conspicuously low attenuation components, but also some more solid soft tissue components too. So this is just fine for liposarcoma, and that's what this turns out to be. Here it is then another year later. You can see it's gotten much bigger, and there's more, the ratio of solid components to the fatty components has increased, and it's the solid components that are probably the more malignant parts of this tumor. So this has progressed dramatically and over the years. I don't know why it wasn't resected initially at the time of this CT. This is outside imaging, and I don't know what the clinical approach was at that time. Eventually, I think this thing was resected. So a progressive, large liposarcoma of the anterior mediastinum. Okay, those are my cases. Thank you.
Thank you.
All right. Who wants to go next?
I can go anytime.
All right, I'll make you the presenter. There we go.
Here's a really interesting case in which an unexpected finding is present. Patient has a complicated history, but at least at this time, there isn't a primary cardiorespiratory illness involved. So we have pacemaker leads, a feeding tube contrast medium in bowel, and surgical material in the upper abdomen. And of course, this is the rather unusual finding on the radiograph. And it turns out to look like this on the CT. I'll skip by this only to say that we thought this was a bronchopulmonary aspiration episode. Let's look at the strange calcifications, and we'll see it's a lot more than, of course, just extensive calcifications related to mitral valve annulus, but there are calcifications in the myocardium in multiple locations. And this one, which is relatively large here, I'll change the contrast here, clearly has relatively high attenuation in the center of it. So it's a partially calcified item. And typically when we see this, we kind of anticipate that if one were to cut into this and look at it with the naked eye, that it would look like caseous material. But it is located in the heart. First time I've seen that. So I looked up and found this article, Caseous intracardiac, a diagnostic enigma. And of course, this one is rather florid, but has very similar findings to my case. So there you are, a very strange case of intramyocardial calcifications. And I think it's the first time I've seen this. Anyone seen anything quite like this before?
I've seen it a few times. And one of the interesting things also, on the paper they show, you can see the areas in the myocardium are enhancing. On the delayed gadolinium images there, you can see it really well in the septum. And so there's certainly an inflammatory component. And the parts that kind of infiltrate into the myocardium oftentimes can also be quite thrombogenic. And so sometimes if you look at the surface, they'll generate thrombi along the areas where either it's myocardial or pericardial that's just pushed very close to the endocardial surface.
What is the clinical context for this condition? I mean, these people, chronic heart failure people, ischemic people, or people with infections or renal failure, or what?
They're not. No one really knows. It's not associated with infection or anything like that. And it's an incidental finding in almost all people. I mean, sometimes even these patients, I think they're pretty much asymptomatic. They can get, some issues with the mitral valve, but usually it's found in asymptomatic patients.
Okay. Wow. Sounds like folks have seen one or more cases before. I think it's my first. Wow. All right, curious. This is just an example of perception and postoperative radiography. So I will show you this patient had surgery, and here is an image that I read on the first post-op radiograph, and I described everything to be okay in terms of support devices, catheters, leads, and so on. Next day, a colleague said the same thing. On the next day, when some of the items had been removed, then I did perceive this. And in looking at it, I could recognize that, of course, it's in the right jugular position, but it has an opaque object going right through it. And of course, it goes all the way down and keeps going down. So at that point in time, I did contact and speak to the surgeon who did the procedure, and he says he wasn't aware of anything unusual at the time of surgery. Now, typically, it's my understanding that when these are put in, they're put in by anesthesia colleagues at the time of surgery. But by all accounts, nothing unusual occurred. But after describing that and saying it looks like a catheter with a guide wire continuing inferiorly down the IVC, they did actually take this out uneventfully. And indeed, both a catheter and a guide wire came out. So I think sometimes difficult to perceive when one doesn't really see something unusual, or it just doesn't fit an imaging pattern for a misplaced catheter in the usual sense, at least, because it's rather opaque and it goes to a funny place. So kind of a bit of a perceptual challenge. So that was unexpected and rather odd. Here is a nice radiograph for residents taking care of working overnight trauma patient. Usually when we see the history of trauma there, you think, okay, blunt chest trauma, next case, but, well, not next case, but blunt chest trauma. See this and something unusual, dilated bowel. Is there something odd over there? But this isn't blunt chest trauma. This is a stabbing victim. So I'll show you the CT now to further clarify what's going on there. I'll go all the way down to give you a feel for where the knife tract kind of is, which is down here. So this is where the knife will pass through, going superiorly through the muscles, and then you'll begin to recognize as I scroll over here. Actually, I'm just going to take this and make it a 3D NPR real fast. and then I'll make this big. Okay, so let's go kind of down here, and you'll begin to see that we can identify the extent of the diaphragm disruption in different locations. So here you can see the intrathoracic herniation of bowel and spleen and fat. So it's a rather large defect. Here is, I believe, the curled edge, thickened but curled edge of a diaphragm right here, and the defect being rather large, going up in this direction. Again, here is diaphragm with the curled edge. So indeed, that is a rather large injury to the diaphragm from the knife wound, surprisingly. And here is confirmation of it. And you can see they measured that there as around an 8-centimeter defect. It's very lucky that the knife didn't do too much damage to other things, as you can see there. But pretty impressive diaphragm. I suppose, you know, if you have a knife going through and it's a certain size, maybe the muscle fibers retract away under respiration and the defect just opens up and becomes rather large. Has anyone quite seen that before? I guess it's not that unusual or unexpected that the defect may be quite big, even from presumably a small knife or a relatively small knife.
Howard, I've seen other penetrating injuries that make rather large tears disproportionate to cause. And I think your suggestion may be true. It's sort of like a, you know, like packing tape or something. You get it started and it just tears. And if you think about the diaphragm, it's, I mean, it's pretty thin, and if you imagine it's under tension at all, it just sort of rips along. I mean, I don't know for certain, but that seems to be my experience, because I'll read an op note and it'll be a much larger tear than.
Right.
And if you look, your images showed that sort of thickened, retracted kind of fragment that's sort of, or not fragment, but fiber that sort of suggests that's exactly what's happened.
Yeah. That it's kind of balled up and retracted into a thicker knob right there like that.
Exactly.
Yeah, pretty impressive. He was lucky. Didn't get too much else. Okay, this one. Yeah, this is pretty dramatic imaging pattern and growth of tumors. So what to make if you didn't have any history about this? So I'll scroll quickly from top to bottom. So of course, here we have ground glass attenuating opacities, GGOs of varying sizes. Some of them are fairly round and discrete. One might imagine that they're forming in the central portion of the pulmonary lobules, adjacent to the lobular membranous bronchioles. And you can see the extent of the abnormality. And then we come down here and we see a large mass. And then the other striking finding are the Cheerios down here. We've certainly shown this before, certainly with the large mass and the rest of the appearance. This is consistent with tumor, presumably with tremendous aerogenous spread, I would think. And then just these interesting growth patterns of tumor growing throughout both lungs. This is a TTF1 positive adenocarcinoma. Typically, if you were thinking of the entity of mucinous invasive adenocarcinoma and take away the big mass, we can see a pattern that looks just like this. But typically, those are actually KRAS positive and tend to be TTF1 negative. So any comments or thoughts about this pattern? Would everyone agree it's probably aerogenous spread? Cells are carried by secretions to all parts of both lungs from the mass?
Yeah, I agree.
Yeah, or a mix of lymphatic and airway. But was this patient, did they present with bronchorrhea and productive cough?
Not that I know of. Not that I know of. Don't think so. Yeah, I think the last one we saw like this, Travis, I think you showed the Cheerios with the adenocarcinoma, if I remember correctly.
This is a remarkable case just because you have different morphologies. Like you show there, there's just more fuzzy ground glass nodules in the upper lobes and then more confluent ground glass and consolidation and then Cheerios. It's really interesting.
Yeah, Very. Yeah, pretty dramatic. Okay, I'll show. Oh, this is just a nice teaching case, particularly for residents. Nice findings that allow one to make a pretty confident diagnosis of the etiology of this lesion. I will show you the CT, bring up some thins to show you what the lesion looks like and some findings in relation to it. So large rounded opacity. We go to the lung windows and we can see that there is an endobronchial component here that's actually visible by virtue of being surrounded by air. And then you can see the mass. Undoubtedly, it is displacing away from it and compressing airways. So perhaps no surprise that it's going to have some secretions in airways around it because of the obstructive component. But a lesion like that with kind of a tip of the iceberg sign and the overall appearance is very typical for what this turned out to be, which is a carcinoid tumor. So just really, oh, and then there was another finding right here, which is, I don't know if you'll see it because it's kind of subtle, but there's low attenuation here that one can readily attribute to a post-obstructive phenomenon. So some air trapping by virtue of bronchial compressions right in here. So just a complex of findings, pretty typical for a carcinoid. Okay, Jeff, those are mine.
Paying attention, did you mention the enhancement?
Oh, I didn't. Let's go back
Look
there.
at it. I mean, these are usually avidly enhancing. Yeah, it's pretty bright for, yeah.
Yeah.
That's pretty good enhancement for an early art. So.
Yeah, so another, yeah, good.
All right. That's in case. All right, we got Seth and Brian on and Travis.
I can show cases. Just got a couple. So this is an interesting case. Came in overnight and was read as having a patient had a known history of sarcoid and had this pretty good sized pericardial fusion, not massive, but probably moderate size, some good pericardial fusion, pleural fusions. What was not seen, which I understand because the phase of contrast can be difficult, is this lesion sitting down here. Kind of, it is hard to see in the right atrioventricular groove, kind of along the inferior aspect of the heart. So this patient was tapped, and then we have a CT that is after the pericardial effusion was tapped. They weren't aware about this lesion, and then they got a subsequent CT because they got a lot of blood out of the tap, and you can better see this infiltrative mass in the right atrioventricular groove, kind of wrapping around the inferior surface of the heart along the RCA, and then extending along the septum. You know, these are always better seen on portal venous phase imaging, which we often don't get because we do most of our studies at 100 kV, and our body folks refuse to scan anything other than 120 kV. So whenever there's a difference, we get the arterial phase, they get the portal venous phase. Anyways, so this was, a lot of people might say, oh, it's AV groove, this is going to be angiosarcoma, but you can notice angiosarcoma doesn't usually have this infiltrative pattern growing along kind of the underlying scaffolding of the heart. So whenever you see a tumor kind of infiltrating along the scaffolding of the heart, you should immediately think of lymphoma, which this was. So it's an interesting case of someone with sarcoid who also developed lymphoma. And some of these nodes were biopsied, and while most of them showed just sarcoid, some of them did show evidence of associated lymphoma, along with the cardiac finding, which is secondary lymphoma. So I don't know if I've seen too many cases of people with sarcoid develop lymphoma, let alone cardiac.
Howard,
yeah.
Didn't Howard show a paper of that, like the sarcoid lymphoma syndrome?
Who did?
I think Howard, right?
Yeah, I think we've shown cases before of sarcoid and lymphoma. Sometimes they are diagnosed concurrently. Sometimes the lymphoma is diagnosed a bit later, and maybe even the other happens. So we used to call that the, I don't know if it's a thing, but the sarcoidosis lymphoma thing, because of the concurrence of them, or one develops after the diagnosis of the other. So that's been described, and some people call it the sarcoid lymphoma. I don't know if you'd call it a syndrome, but yeah.
No, the two have. I just hadn't seen one presenting with a
Okay.
cardiac. I should have said better. I hadn't
Yeah.
cardiac leak.
Right.
One
Yeah.
more question, Seth. What about angiosarcoma enhancement? Is that helpful diagnostically? Do they enhance the lives of the vascular tumor?
Yes, absolutely. So on a portal venous phase, let alone an arterial phase, you would expect this to be much more avidly enhancing if it was angiosarcomas. So that is a good point. I do have a couple of cases of lymphomas that are, for some reason, unbeknownst to me, avidly enhancing and have fooled me. But nonetheless, you're right. Angiosarcomas would be much more avidly enhancing, which would help differentiate it from lymphoma. But also the kind of infiltrate, it's going along the septum here. This infiltrative pattern is also quite atypical for angiosarc, which just turns out to be a big mass, usually extending anterior.
Seth, one other question too, because I was thinking, like you said, this looked more like lymphoma. The other thing is, don't angiosarcs usually derive their blood flow from the RCA, and it's often dilated as a result because of increased flow? At least a couple of the cases I've seen, that's been the case.
No, I have a lot of cases with beautiful parasitization of RCA flow on CT and cath, and in those cases, the RCA isn't that dilated. You see a lot of little. I mean, I have to go back and check. Especially on
the collaterals, right?
Laterals are really impressive, and there aren't many. Although it's not a gated study, there aren't many here. But that's another good point. I don't know if I've seen it. I mean, it makes sense it would be dilated, but usually they're so infiltrative around the RCA. I wonder if the compression of the tumor itself may prevent that from happening to some degree. I don't know. I haven't seen that, but it may happen.
Yeah.
But yeah, the angiosarcs often have big feeding vessels coming from various lesions.
That's a really nice case.
This is a case of something. I'm sorry, this thing is a little slow. I had never seen, and our surgeons had never seen either. So this was a guy, and I'm sure it's happened. I don't know why we haven't seen it. It's like one of those things like, I've never seen that, but it doesn't make sense that you should have seen it. So this is a guy who presented for CTEPH workup, and he has more, he's CTEPH-y, but he's also got, you can see this PAPVR. So the question was, and he has some findings of pulmonary hypertension, and I'm sorry, it's taking a while to load. And he definitely has, you can see areas that he clearly has CTED or CTEPH. But the interesting thing here, if this thing is really taking its time, apologize about that. So you can see vessels go away and there's clot. So look at this PAPVR, okay? So we have PAPVR, left superior pulmonary vein kind of drain. We've all seen that. What I haven't seen is where this vein also connects to left atrium. So this vein, this PAPVR has dual connection to the anomalous systemic venous drainage, but also its normal pulmonary venous drainage. And I've never seen that. The surgeon had never seen that. And then we were kind of contemplating giving his pulm, because normally this would be a left to right shunt from the LA to the anomalous vein and then up and around into the systemic vein. But now, given that his pulmonary pressures are quite high, we were surmising whether we actually have retrograde flow and a left to right shunt turn into a right to left shunt, because the pressures in the systemic veins are actually higher than the left atrium, which they are. Anyways, just going to ligate this vessel. So instead of normally redirecting it with pericardium and kind of plugging it into the left atrial appendage, they're just going to cut here and ligate it and let it have its flow into the left atrium normally. Has anyone seen this dual connection?
I showed one of these way back when I was at Emory. I've seen it once, and this is a persistent levoatrial cardinal vein.
Is that what it is?
Yeah, that's the entity. And I want to say mine drained into the left atrial appendage, but it had that bilateral communication with the brachiocephalic vein as well. And I found a couple case reports back then, and there was one of like a patient having a TIA, like you were saying, because of change in pressure, I think if you Valsalva. But if you look up persistent levoatrial cardinal vein.
Doing that right now. Yeah, that's really, okay.
Yeah, that's a really pretty example.
Okay.
Levoatrial cardinal vein, yeah.
Okay, I will tell him. I wonder if, yeah, I'll ask him about, because they're going to take it and take him for CTEPH and at the same time ligate that vein. I wonder if that is like a well-known treatment for this. So it's associated with I see a bunch of things with choriotriatum, which I don't see with him. And then the last one, which I was going to show irrespective of kind of the session Jeff and I had a little earlier, is a patient that we had in another patient we had in our CTEPH clinic last week. And this is a patient with dermatomyositis who was sent to us for thromboendarterectomy for CTEPH. And again, I apologize about the delay. And this becomes the distinction, and not always easy, between in situ thrombus versus embolized material or embolized thrombus. And you know, it's something that we see sent to us quite frequently. Now, this patient does have a few areas where, you know, you can see sorry, this thing is just taking its time. There's really no obstructions at any level. And then you get down here and you see this kind of erratic thrombus along the wall. It extends into the right middle lobe and the right lower lobe branches. You can see it's sending into the right middle lobe, lobar artery, and then the basilar segments of the right lower lobe. Man, this thing is really slow, I'm sorry. And you can also see the patient has emphysema and then also has pulmonary fibrosis, but this thing wasn't obstructive. And, you know, I said it looked like, you know, in situ thrombus, and the CTEPH guys were like, oh yeah, absolutely. This is not CTEPH. We see this all the time with people with bad fibrotic lung disease. You can see the degree of pulmonary hypertension. This patient has massive left atrium, you know, really big in hypertrophied RV, flattening of the septum. And there's really no CTEPH anywhere else. It's just, and even here, there's no real CTEPH, it's just kind of layering clot. None of these vessels are obstructed. And they're saying, even if it was, which they don't think it is, even if it was CTEPH, there's really no purpose to, you know, restoring flow to these lower lobes. I mean, they're just completely destroyed from the fibrosis. But this is a patient with known dermatomyositis with what our multidisciplinary consensus was to be layering thrombus, and it's in mural thrombus, and it can be quite difficult. You know, for us, we look for other evidence of disease or areas of clear areas of multiple occlusions distal to the layering thrombus. But I think this is something I struggle with, and we all struggle with. But in terms of our guys, they seem pretty confident about it quite frequently. Anyways, those are my cases. And if you look at the dual energy scan, there's no areas of, it's not going to load, but there's no areas of abnormal perfusion anywhere. So those are my cases.
All right. Travis or Brian?
I have two. Brian, if you have some.
I have one I can show real quick. Or
Or I guess Jeff gave me control. I'll show mine.
Okay, go ahead.
Sorry about the confusion. There we go.
All right. Does everybody see a zebra?
Yep, that's awesome.
All right. I'm glad you. I'm glad in particular Seth is on here with his AIRP experience or AFIP, and then everybody else if you've ever seen this before, because I had never heard of this. So this is a 67-year-old, and this is an outside CT, so it's thicker sections. This was just being done for dyspnea, and he was incidentally discovered to have this multinodular, what was called a mass in the anterior mediastinum. As you can see, it's soft tissue attenuation. There's looks like several discrete little nodular components to it, and then fat interdigitating within this. This went to PET, and you'll see that it does have some metabolic activity. The maximum SUV was something like 4.8, and he didn't have
67.
67, yeah. So he went to surgery, and so we just were alerted to this after they took it out, and no myasthenia gravis, no other paraneoplastic stuff that you would associate with thymomas. He has no rheumatoid arthritis or anything. This isn't just like nodular thymic hyperplasia. Any guesses on really rare things of the thymus?
Thymolipoma.
I was gonna say thymoma arising in a thymolipoma.
Ooh.
The answer is thymic cholesteroloma multifocal.
No, really, never heard of it.
Cholesterol clefts admixed with scattered non-necrotizing foreign body giant cells and granulomata with cystic-like architectural background in mature thymic tissue.
Never.
And yeah, so yeah, okay, good, because nobody else had either. Here was one case series, and our pathologist had apparently come across this, but it's benign. It's, as they say, it's tumor-like. And these cases all seemed similar. They had masses between 2 and 6 centimeters, and they just have these cholesterol cleft granulomas with a foreign body giant cell reaction. So the question is whether these just cysts become inflamed, like thymic cysts become inflamed, and then develop this granulomatous reaction and this inflammatory reaction, but nobody really knows. But now you have one for your teaching file.
That's pretty crazy.
Cool.
Yeah,
Do they have gross in that? They should send that to the archives.
FIP. Yeah, they do. They did a robotic assisted thymectomy, so they have the whole thing.
You know what puzzles me? If the word in the description cholesterol is really only referring to the cholesterol clefts, right? Then if you think about just cholesterol clefts in general, and we not uncommonly see that in the context of chronic fibrosing lung disorders, cholesterol clefts can be produced by virtually anything, and they're not representative of anything. So if I understand this correctly, the cholesterol clefts just indicate there has been something there that's produced a granulomatous response, and it's associated with cholesterol clefts. And maybe they shouldn't really put the cholesterol in there in that sense, if I understand it correctly. They should call it something else.
Yeah, I don't know.
Yeah.
But now you can say you've heard of it when your pathologist.
Cholesteroloma. Cholesteroloma sounds like the primary lesion is cholesterol, whereas with the granulomas and stuff, it isn't. I mean, I'm speculating here because I've never heard of it, but it seems maybe it's mislabeled, or in a way. Anyway.
Okay, here's another one and I'm curious on your thoughts on this entity as it is diagnosed. So this patient, and this is, I think, an important part of the history, has a ventriculoatrial shunt that they've had since like 1990, so 20 years or so. And he comes in with dyspnea, and you'll notice that there's this calcification projecting over his heart, and you can see it on the lateral view as well. So it's to the right of midline, and it's mostly like right atrium, perhaps right ventricle, and it's a little bit more posterior than we'd expect. And there's also something here that, as I will show you the CT, but there's some calcification in his heart, and this is not the same thing that that Howard showed, but what you will see, and this was actually visible on the radiograph as well. I didn't, it easily mistaken for just calcified granulomatous lymph nodes. But this patient, you can see this is chronic calcified stuff in the left lower lobe. This patient was actually referred to our CTEF clinic here. You can see same thing there. And then this was the big honking thing in the right atrium. And I don't know, I guess that thing that looked like it was more in the RV outflow tract didn't pan out. So we thought, given his indwelling catheter and whatnot, that we thought this was probably just all calcified, like chronically calcified thrombus, and you can see this. So they went and did basically an embolectomy of all that stuff. And they're calling this calcified, cardiac calcified amorphous tumor, or this CCAT. I have actually shown one case of this that a UCSF pathologist called this too. So I've had pathologists from 2 different institutions actually call this thing. It's not a tumor. I'm curious what your thoughts are. I mean, to me, it just seems like it's chronic calcification.
Yeah, heavily calcified thrombus always gets called this. And we had cases of this, and our pathologist at Maryland was always said it's basically just chronic calcified thrombus, and for some reason it gets called this instead of chronic calcified thrombus.
Okay, because somebody needed a promotion, so they had to write up a.
Yeah, it's a little different, but I don't understand. But he basically said it's calcified thrombus, and for some reason it's really shouldn't be called an entity, but it is.
Okay, and I suspect it probably did just embolize from the it probably all started in the right atrium because this guy's had this indwelling ventriculoatrial catheter, and then maybe it flicked off, or maybe he just had separate, calcified things or thrombi that then subsequently calcified. I don't know, but yeah, I agree. It's kind of a, I think we just call this calcified thrombus, period. But that is an entity that gets floated around in the pathology literature.
If I remember, it's usually a valvular lesion, right? I thought it was usually maybe.
I pulled up one other case. This is the other one I had from UCSF, and I think this one was in. I have to remember where it was. Yeah, this was one that was in the RV, just sitting there. And I saw one that was in the left atrium because it was a case report just discussing a TIA that a patient presented with because of this. But this was the other CCAT I had, basically just fancy term for calcified thrombus. And this one had embolized as well.
Oh.
Yeah, so I'm just reading, and this is pathology, basically saying it's calcium mixed with chronic degenerating blood elements and inflammation. I mean, what else? I mean, that's.
Yeah, I know.
These are nodular calcium and background degenerating blood elements, i.e. thrombus, and chronic inflammation, which is induced by chronic thrombus. So I'm not, this is the paper that describes it.
There's probably cholesterol clefts in it too. We can call it pulmonary artery cholesterolomas.
And this is the initial paper describing it. Said all these lesions may represent calcified thrombi. The clinical presentation does not suggest this. Thus, we call it calcified amorphous tumor. So it's basically calcified thrombi, but they can't explain the calcinized thrombi, and so they name it something.
Instead of saying just idiopathic calcified thrombus, they have to give it some fancy name.
And this is the original paper in 1997. So, and it does all, I'm looking, it does, a lot of the cases are from valves, but anyways, they don't have to be valves. I think the 1 or 2 cases I've seen in the FIP archives are on valves, but.
Okay, thanks.
All right, Brian, you can go.
Okay, so this is a 37-year-old man with shortness of breath. You can see a radiograph here showing prominence of the MPA segment. He presented, he had relatively poor echo windows, but they thought that they saw pulmonic stenosis. And so they were teeing up for a pulmonary valvuloplasty and wanted to do a CTA prior to that. Interestingly, so on the CTA, and I apologize for the relatively poor image quality, you can see there's two normal looking anterior leaflets of the pulmonic valve. And then it looks like there are two posterior leaflets of the pulmonic valve with a left and a right and a thin commissure between them. This is a diastolic phase, and you can see there's a fairly open aperture, about 1.4 square centimeters. This is the valve during systole. It's a little hard to see the commissure between the posterior leaflets, but you can see there's really no stenosis. It's wide open, at least 3 square centimeters. On a sagittal imaging, you can see the PA is quite enlarged, and the annulus and the sinus of the salva are relatively normal in size. And then you can see that the RV is fairly large, but really not much in the way of a right to left ventricular bowing on the multiphase. So I hadn't seen this entity before, but I think this might be a quadricuspid pulmonic valve. I think Seth has showed a quadricuspid aortic valve before, but this is a pulmonic variant. And in my reading about this entity, kind of like bicuspid aortic valves, they can be associated with an arteriopathy, which can lead to enlarged vessels, even in the absence of valvular stenosis.
Oh.
So,
This isn't, so Brian, I showed one of these at UCSF. This isn't a patient that happened to go to Davis afterwards, is it? Because it's the exact same story. It was like incidentally discovered and they had an enlarged pulmonary artery.
oh.
I remember my colleague, I think my colleague Kim had found like papers talking about the association between pulmonary artery aneurysm and quadricuspid valves.
No, they have not been to UCSF as far as I can tell. Sorry.
That's awesome. You've got a gated study. I didn't have that on the one I had.
Oh, nice. Yeah.
Very nice.
Very cool.
Yeah, cool. That's my case.
All right, thanks. All right, I have time for a few here. Okay, so going on our anatomy theme today, and Howard, you will like this case. This is just an incidental finding. This was on a, I don't remember what it was for. And I've not seen this variation. So we've talked about top pulmonary veins where you have a vein branch that usually drains posterior right upper lobe or superior right lower lobe, but usually the top posterior, and it comes in behind the right main bronchus like we see here. And they usually drain either usually into the superior vein. Sometimes they go into the left atrium proper, but this one, I've never seen this happen before. This little guy here actually goes into the mediastinum and crosses over and enters the left superior pulmonary vein to then enter.
Oh, no.
So is it an aberrant top pulmonary vein?
It's a meandering top pulmonary vein.
Yeah, it's just cute.
Mediastinal meander. Mediastinal meander. 2 M's.
Yeah, it has absolutely
Wow.
no clinical significance other than, I guess, if you're going to do a lobectomy, you need to probably want to know about it so you ligate it and don't have a little bleeder intraoperatively. So, but yeah,
Because there's some other little vein that right below there, that one that's going right behind the bronchus intermedius as you scroll down, right there.
Yeah, that's just a little branch that goes into the superior vein. Yeah. I don't know. I've never seen one before. At least I should never notice one before. This is another interesting case, and I would love your thoughts on this. So this was an incidental finding. This was rule out aortic dissection case. And first thing you'll notice is there's the right hemithorax is small, the pleura is thickened, and it's calcified. And there's some calcified lymph nodes. And then we get down here to the hilum, and then there's just this lymph node calcification, sort of this soft tissue here, and quite an extensive, what I would call fibrothorax. It's sort of plaque-like, but there's also pleural thickening. This guy was, I think, younger. There's nothing on the left that looks anything like asbestos plaque. And then on the contrasted study, you'll see that if we follow out his vessels, his there's a little bit of, right around that calcium, we'll see the interlobar pulmonary artery just drops out. The veins, and then this vein right here, you can see that's a little wisp of contrast in it, but it looks like that vein is out. And there's a little bit of narrowing of the middle lobe bronchus. So this is a variant, at least in my mind, of fibrosing mediastinitis. We call it fibrosing hilaritis, but it's the same concept. And we have the calcified lymph nodes. Oh, and for David, you'll see there are calcifications in the spleen. There's one right there. There are a few others right there. So presumably old histoplasmosis. And I don't have trouble with that diagnosis. What I can't explain, and it may be completely unrelated, is the fibrothorax. Because there's, I don't have a good reason for this pleural disease unless he had had some bad infection because of this obstruction. I mean, there's some parenchymal bands we see. There's sort of developed
like a
rounded up like this. Go ahead.
Can you, with histo, can you not see like you do in TB and cocci? Can you not get a primary pleural inflammation or associated?
It is
pleural?
Very rare.
Okay.
I mean, we see histo all the time, like just incidental. And I've seen, and it's hard to always ever pinpoint it there. It's hard to isolate it there anyway. A lot of times it's a presumptive, but I've not seen really much pleural disease with endemic fungal infection around here. So I can't really explain. I mean, it looks like an old empyema maybe.
Yeah.
So maybe, and I just don't have any history. I have no old imaging. So my hunch is it was unrelated. But I've never seen I mean, we've seen transpleural collaterals, but this is really fibrothorax. But I thought it was a nice example of a fibrosing hilaritis.
It's funny. You're right. I've never made the distinction. I just always call it fibrosing.
Yeah, I
mean,
mean,
right. It is just.
It's the same. It's the exact same thing. And this one's a little interesting in that, I mean, it just took out this entire pulmonary artery right there.
Yeah.
And the vein somehow managed to, at least it's.
How is the vein filling the right? What is filling that vein? If you
Well, there's got to be some collateral flow through something.
That guy from the bronchioles.
Yeah, there's some bronchial.
There's some or just the spontaneous systemic venous.
Probably, yeah.
Collaterals that occasionally develop.
Yeah.
But yes, that's a really good question. I just looked up. There's one article saying there are less than 20 case reports ever of empyema from histo. So it means it happens, but just incredibly rare.
Yeah.
That's a good question.
Yeah, it's just that's one of the things that I use when I see, if I see a big pleural effusion, I typically sways me against endemic fungal infection. And even with blasto, we tend to see small. If there's an effusion, it's pretty small, but I've never seen a empyema from it. So anyway.
And Jeff, you didn't see any encroachment on the airway that would have predisposed to.
Well, there's some mild narrowing. I'll go to the non-con just because it's a little less artifact. The middle lobe bronchus is a little tight.
Mm-hmm.
So it's, I mean, that's what I like I said, this guy just showed up in the emergency department, so I have no old history, but I suspect he's had an old pneumonia, and whether it's related to this or not is unclear, but he's at least at risk for poor clearance of that lung.
And no rib fractures that would have accompanied, say, trauma with blood in the pleura as the cause of that.
Right. Yeah, no, nothing that got it. I was excited about, and you can see. But that there's the extrapleural fats hypertrophy. This has been there a long time, the calcification. But it's just, in my experience, it would be really unusual to see this exuberant if this was all asbestos related and nothing on the other side.
Right.
All right. Let's see which one. I have time for one more real quickly. This is just kind of an interesting case. So this is a patient who has a known diagnosis of sarcoid. There's no question about that. You've got these nice calcified lymph nodes with a mix of dense and sort of putty or icing sugar. And on the last scan, it was observed that there is a little communication or either diverticulum or a fistula between the bronchus and the lymph node. And the way I came across this is on this scan that I was looking at, there was gas here in this lymph node. And so when I went back to the old case, I saw that there's a little diverticulum there. You don't see that as well, and it's a big patient. There's a lot of motion, but you don't see that there. So my presumption is this is a fistula, and it either closed and there's gas trapped in there, or it's just we don't see it because of all the motion. You kind of get a sense maybe there's a little divot there, but who knows. But I've seen this, we've seen it with TB and infection, but I don't think I don't recall seeing it with sarcoid. Has anyone ever seen a broncho, a lymphadeno, whatever, fistula or anything from sarcoid?
No, I don't think so.
Because I think
The only-
sarcoid nodes is pretty hard and just sort of like contained, but I mean clearly there's a defect right there. It's not doing anything, and these scans are at least a couple years apart. But it just, what caught my eye was that gas in a lymph node, because I'm not used to seeing that in sarcoid at all.
I mean, I've only seen it once with TB, and it was a bunch of nodes, but yeah, I haven't seen it with anything else, but I've only seen it once.
Yeah. All right. Well, I have to run to another meeting, but thanks, guys.
Okay. Thanks.
I'll talk.
That was a great answers.
Good. Excellent. Bye.
Thank you. Bye-bye.
Thank you. See you, Brian.